Good morning, everyone. Welcome to the Parkinson Association of Greater Daytona Beach's ongoing webinar series, You, Me, and PD. I'm Vince Kinsler, the Executive Director. In addition to being a top-rated neurosurgeon, our guest today, while obtaining his doctorate degree in neuroscience, actually spent 3 years of his fellowship training in Grenoble, France, under the tutelage of Dr. Anim Louis Benabid. This is the physician who is actually credited as the father of what we know today as deep brain stimulation surgery. So that's very exciting to know that we've got this kind of connection today. Our guest is also currently Chief of Neurosurgery at Baptist Medical Center in Jacksonville, Florida. Please join me in welcoming Dr. Bradley Wallace. Dr. Wallace, for quite some time, really after the early splash of the advent of DBS surgery, really for probably about 15 or 20 years, things were as they were right from the beginning. And then kind of, it's almost like serendipity or synergy or something goes on out there. And then you start to see things evolve and evolve quite quickly. And I've actually have read recent papers on DBS surgery, not so much specific to Parkinson's, but certainly to include areas of epilepsy, of depression, where we're starting to see some rapidly advancing technology in this area. So it's quite exciting. But you know, with this recent evolvement and rapidly changing landscape and this new technology, you know, where are we today with up to speed? And then, you know, how soon are we going to see something more advanced? Can you bring us up to speed on that?
Sure.
We're looking forward to hearing it.
Yeah, well, no, Vince, very kind introduction, and I appreciate you guys having me. Can you guys hear me okay on your end? Everybody
Yes.
good? Okay. Well, so, you know, I think where are we at and what's on the horizon, you know, is kind of broken down into two categories. On the one hand, you know, it's increasing applications, you know, like you alluded to, things like epilepsy and depression and obsessive compulsive disorder. Won't spend a ton of time today talking about as much those things as the other category of major advancements, which is the improved technology that is underlying, you know, the DBS platform. And you're exactly right. You know, historically, we've had such great success with DBS. Particularly for Parkinson's and for essential tremor, and the technology that we had was sufficient to provide those things. But in recent years, and obviously there's been a lot behind the scenes for many years, but in starting last year in summer, some of these higher tech devices have become available, and we've started utilizing those. And there's really kind of two big changes. One is in the battery or the neurostimulator device and its ability to not just send a signal, but to receive them or to sense what's going on in the brain. And then the other component of this is the electrodes and the ability to direct stimulation. And I'll get into that a little bit more. But you know, the bulk of what I really kind of focus on is going to be, you know, some of the technological advancements that are not just, you know, on the horizon, but are actively being, you know, unveiled now, and we're using them. We started implanting those new batteries, and I'll talk more about that in a few minutes, last summer. And then we've just done our first round of the new electrodes. We've done 3 patients so far, but that just came out late summer of this year, and so we're excited to see some of that. So you know, it's my understanding that a lot of the folks in this group are pretty savvy and have a pretty good understanding of just DBS in general. I never like to assume too much, and so if any of the folks that are participating today have questions about just DBS in general, you know, I'm certainly happy to go in whatever direction. It's a fairly small group today, and so we have the luxury of, you know, I think keeping it a little bit you know, less formal, and hopefully that we can tailor it to talk about what the folks are really wanting to talk about. So on that note, you know, they do have a slide set that they provided to me, Medtronic did, and the slide set, we had one originally, but we thought it was maybe a little on the basic side. And so the slide set that I had was a little geared towards care providers, but we thought it would probably be a little more useful. So we'll just kind of run through this as a start, and then I'll circle back around and kind of break things down here. So give me 1 second here. Where did that go?
There you go.
Okay.
Thank
All right.
you.
Well, so we'll just kind of run through these, and then I'll kind of give you my just general thoughts to kind of summarize things. So in working through this, the new system is broken down here on the bottom, and it's there's kind of three components to this. One is the actual new neurostimulator, or the battery, the pacemaker device that is placed underneath the collarbone. And this is a pretty significant and radical change. That's called the Percept. And this whole idea of brain sense is being able to read some of the signals within the brain. The second part of it is going to be our SenseSight. That's the new electrode, and it's what we call a directional lead. And then this third part is really the OptiStem, is really just the interface, the ability to program and record events that come with each of these that are provided to the patients. So it helps both the folks programming as well as the patients be able to get things in. So we'll start with the Percept, the brain sense technology here. Again, the big deal about this is that historically it's been what I would call a one-way street. Okay, so there's nothing coming in historically. The battery can't read or sense anything that's in its environment. It's only got the ability to send stimulation out to the brain. So the big deals about it are obviously the brain sense, which we'll talk about in just a minute. It also is MR compatible. I mean, there are some restrictions and some techniques that have to be applied, but the ability for folks to have an MRI scan and have it safely has been dramatically improved. And then the smart battery and digital diary, these are again just features that help. The smart battery gives you an accurate prediction as to how much battery life remains on the device. And the digital diary, we'll take a look at that, is the ability for folks to log in things that are occurring, whether it's taking medications, increased rigidity, dyskinesias, any of those things. They can log that in what's referred to as a digital diary. So the big deal is with the sensing component of it. Let me see if we have some slides. And again, the directional lead, the way that this is sensing things with this new lead, and to be clear, that brain sensing is capable even with the older electrodes, paired up with the new Percept. But the new electrodes, they uniquely have this directional lead system, and so let me just sort of give you a silly analogy that I think will help people really kind of understand kind of the two big deals. And this is admittedly a pretty silly analogy, but I think folks will get it. So the analogy is, imagine if we had a huge garden, and we had an irrigation system for the garden, and we were having problems with our garden because part of the garden was too dry and part of the garden was too wet. It was just, part of it was in the sun, part of it the drainage wasn't good enough. But we have this irrigation system with these 10 sprinkler heads, and every day we're getting up and we're turning it on, and you get one choice. You either turn the whole thing on and every one of those irrigation heads, waters the garden. So the parts that are already overwatered are getting, again, too much water, and the ones that are too dry may not get enough. There's no intelligent way to get any feedback. We're turning on the controller from the hose bib, and we can't see which is dry and which is wet, and so we're just kind of stuck with it. Okay, and the analogy that I'm going with is it's sort of like our current state, our recently current state of DBS, in the sense that we have no idea if we're stimulating structures that we shouldn't stimulate, and we're creating some side effects. We have no idea if certain activities are occurring in the brain in which we need to modify the stimulation, where we need to modify it. And so with this new system, both in the ability to direct the stimulation and in terms of being able to sense what's going on with the brain, it's sort of analogous to if all of a sudden we had our garden, but we had a bunch of sensors in our garden, and we could see which part of the garden was too wet and which part of it was too dry, and then we had the ability not only to sense the needs, what the state of the garden was in terms of irrigation, but we also had the ability to direct our irrigation and control it. So the dry parts we could provide more water for, the wet parts we could reduce the water. So stupid analogy, but I think you guys kind of get it. And yes, our original sprinkler system where we just blindly irrigated the whole thing uniformly. Yes, it kept the garden alive, but it was less than perfect. The ability to respond to changing conditions in our garden, so to speak, and the ability to provide irrigation or therapy where it's really needed and when it's needed. You can imagine, even though I'm speaking in kind of broad terms, the power that potentially has in the ability to provide better treatment with DBS. So the brain is comprised of lots of neurons. There's lots of electrical activities. We cannot monitor the specific electrical activity in a meaningful way of a single neuron, but we can take big groups of neurons that are creating electrical activity and create something that is measurable called a local field potential, or an LFP. And this is basically just sensing activity in different parts of the brain from an electrical standpoint. And one of the nice things about this new technology is that it is capable of very accurately evaluating the local field potentials, and so we can get the activity within the brain. Now, admittedly, this is still fairly new technology, and even though we understand what certain electrical signals in the brain mean, we're still figuring that out. And so one of the things that's being done right now is that as we implant these folks with the Percept, and we put in the new electrodes, and even again, with the previous electrodes, we're able to start to collect data, and as we collect that data, we can start to correlate it with the clinical states of the patient. And so, for example, if somebody's having significant rigidity, with the ability to tag that event and say, hey, I'm having real rigidity problems, the device is recording actively what the brain electrical activity looks like, and we're looking for correlations to see. So if somebody says, yeah, I'm having increased rigidity, or I'm really on my medication and this is what my brain looks like electrically, we can start to correlate that. Now, right now, it's still in what I would describe as sort of a data collection phase, and ultimately, what will happen is you can imagine if is you end up with what's called a closed loop system, where somebody has rigidity. You see that electrically. We've now confirmed that sort of signal activity that's being recorded correlates with this problem. And we can see, and the device will ultimately, again, this is not currently how it's working, but this is exactly where it's headed. The device will be able to see that increased rigidity, and it can increase stimulation in a way that would counter that increased rigidity. And then, and it gets feedback to see what it's doing. Can you guys still hear me? I got a signal that said my internet connection was unstable. Vince, are you still able to hear me?
I am. Yes, we can hear you.
Okay, good. So, but basically, you end up in a situation, you have, as an example, more rigidity. The device responds, starts to stimulate, maybe at a greater level or in a certain area to help treat that rigidity. And and it can see, the response based on the changes in electrical activity as it modifies the stimulation in terms of whether it's doing its job or not. So, the SenseSight, the directional component of this, again, we don't want to get overly technical, but let me see if we have one that shows kind of that sphere. So imagine that, the electrical, I think we may have a slide coming up, that the electrical stimulation historically, let's say that you've got a sphere around it, or imagine even as, that there's just a ball or a sphere, so that when currently, we can modify the width of that sphere. But let's say that there's a structure over here that we want to stimulate. Let's say it's a portion of the subthalamic nucleus. But over here, we've got some motor fibers that control your eye movements, or the motor or the motor function in your arms. We want to stimulate the guy over here, but as we start to stimulate that sphere of stimulation to stimulate our target on this side, we're also inadvertently stimulating the structure over here. And if we can get really good stimulation over here and really provide significant improvements in whatever the target symptom is. But as we're doing that, we're having to go to increased stimulation, which spreads that sphere of stimulation even further over on this side. And when we're getting that excellent control of tremor or rigidity or whatever it is, we're inadvertently having to stimulate motor function or motor fibers, and we're creating, some facial contractions or some double vision. And so we're limited in getting that. With the directional component of this, now we can selectively stimulate in one direction and really ramp up the stimulation, get a better overall benefit. And at the same time, we're reducing our side effect by not stimulating the area that we don't want to stimulate, where there are important structures. So I'll pause, Vince, and the rest of the folks. Does that make sense? I'm describing the advantages of this sort of directional lead technology.
Yeah, very, very interesting. There are some questions, but I think I'd like to hold on those if we can just keep moving forward, Doc.
Okay, sure. So that's then there's some other smaller technical things. It's more flexible. It's thinner overall. These are more durable electrodes, and even though we don't see electrode failures or mechanical complications commonly, there are obviously some advantages in how they have designed this. The OptiStim, and admittedly, I don't, typically the way it works for those of you who have a DBS stimulation system in place already, the surgeon typically does the implant, and it's typically the neurology, side of the camp, typically not me, that does most of the stimulation. But it's my understanding that, with this new OptiStim, in addition to folks being able to tag different events, we can also program the electrodes in very specific ways. So instead of just creating, a sphere again around that electrode, each independent electrode can be uniquely programmed. So again, it gives it a tremendous increase in the ability to tailor somebody's stimulation to reduce side effects and to enhance, the benefits. And then this whole shape lock control feature, instead of giving technical control of the programming to the patients, it creates a more user-friendly ability, and it sort of allows folks not to get too crazy with their programming. They're able to kind of modify some of their programming depending on their situation in a way that is confined to parameters, so that you don't push things too far, end up misprogramming yourself in the end. But there's a big deal that this multiple rates that you can program the rate and assign that to any of those independent four electrodes or contacts within. So not just a directional thing, there's also a big deal component in being able to tailor each of those independent electrodes, and not just create a stimulation out of one or between one or two in a constant rate. So this is just kind of showing some of the different components here in Jacksonville. We use the Mazor robot, which is an intraoperative CT scanner, which is a little bit different. So for those of you who are familiar with our camp here in Jacksonville, we don't use the head rings. We use the robot, which is kind of nice to not have to attach the halo on somebody's head. We just attach the little robot through a little base ring. But this is just showing, the different components. You can see here's that patient programmer, which is can be used, I believe, on a smartphone as well, and sort of an iPad type platform. And then this is a scanner over here, but again, we use a little bit of a different one here in Jacksonville. So tons of data have gone into this. We've got 5 randomized controlled studies, 100 clinical studies. Lots of folks have been implanted now. 175,000 folks worldwide have undergone DBS. And I say this frequently. Out of all the things that we do in neurosurgery, I'm not sure that DBS is not our most well-studied, well-founded, scientifically driven aspect of neurosurgery, across the board. So the brain sense technology. Again, this slide is just saying, hey, somebody's Parkinson's disease is not just a static condition. Things change. They can be completely off their medications and have significant symptoms. They can be on their medications and have good tremor control. You can get too much of a good thing and end up with levodopa-induced dyskinesias. And this is just kind of showing, that as the day progresses, that you can end up with lots of fluctuations or changes. It's not a static thing. And so, some of the challenges are, what's going on when these occur. When somebody's symptoms are really severe and they're off their medications, when they're ending up with their, levodopa-induced dyskinesias, what does that look like? And you can't rely just on motor diaries, and you're missing a portion of the picture. So here's some examples of using some of these brain signals. So this over here is one that just is showing. And again, I apologize. This may be a little technical, but the bottom axis here is showing worsening symptoms as you move to the right. Better symptoms as you move to the left, and then these are a specific type of these electrical signals that are called beta local field potentials, and you can see it correlates. So in this particular situation, they're looking at akinesia, slowness of movement and rigidity, and as the symptoms worsen, so does the beta LFP activity. So it's just showing that we can actually correlate some of that. So, and if we come over here, this is showing that this particular person, this is kind of their baseline beta activity. So this person is probably having a decent amount of rigidity. And here they're applying 1 volt, a small amount of stimulation, and it's not really doing anything. The beta is still going, and then as the amount of stimulation applied increases, then you start to see some suppression, of these beta waves here, and so the point is. And then this is just showing that, hey, wait a minute, now we're suppressed, but we're starting to see some activity that we know is correlated with a side effect at 3 volts. So that's too much. So this is just an example of how, again, this is kind of where this is headed, this sort of closed loop deal where, ultimately you will end up with this being an autonomous feature where the patient has a baseline, rigidity at just this sort of uniform 1 volt wasn't enough. 2 volts, that was good, but wait a minute, we went to 3 and we started to see some side effects, from an electrical activity standpoint. And so we're going to back off and hold at 2 where we're getting good suppression of the activity that's correlated with rigidity, but we're not creating side effects. So a little complex. Vince, I'll use you as the canary in the coal mine. Does that make sense? How I'm describing this?
Yeah, no, that makes perfect sense. Actually, the graphic is quite good. Yeah, no, it's good stuff.
Yeah.
Easy to follow.
So again, this is this is just showing on the programming that there is a correlation between some of this activity, and then this allows the patients to be able to log events. So they're seeing that, hey, you know what, I took my medication and look at this. This activity has improved. So we're just able to kind of make sense of some of the findings with the outside world. So the electrical activity gets correlated with what the patient is experiencing by being able to enter that data into the patient interface. So again, right now it's in a state where I would describe it as somewhat of a data collection. But this is all geared towards, the more we understand how that activity correlates with what the patient is experiencing, that ultimately is going to lead to more of this closed loop type future application. And so this slide is just, making the point that, in the end, what we're trying to do is to utilize some of this data to maximize, the on state or the well-controlled, Parkinsonian state, as opposed to the off state, and how do we do that by modifying the stimulation in a way that meshes with the patient's symptoms or use of medications, their reporting of dyskinesias or increased rigidity and so on. So again, there's a variety of, this is just showing some of the different things. I think there's 5 different events that, can be logged in. And basically these are things that, hey, I was exercising, or, what, I noticed I had some dyskinesias, or I was on in terms of my medication, and this is when I took, so you're able to very easily enter in that data as it occurs. So this gets into the again, the fact that 3 Tesla MR imaging is available. Obviously, the less powerful one, 0.5, but there's still some restrictions. But this is obviously a pretty big deal. This is just a slide that Medtronic studied and found that 70% of the folks that are DBS eligible patients, some point in the next decade, are probably going to need an MRI scan. And so, the inability to get an MRI scan, and these are typically things that are totally unrelated. They're just general medical issues that need evaluation using MR imaging, which is kind of our key modality as you get older. And that 62% of these occur outside of just the head and neck area. And so the ability to have those MRI scans, could be quite important for a lot of folks. And obviously very happy to see, those restrictions relaxed. This is just showing, that the programmer too can evaluate to make sure that the patient's, safe to have an MRI scan, and it can create that report. So a lot of the things that have to be done by the clinical representatives and behind the scenes, looks like now are going to be able to be more streamlined with just the technology and the user interface. So these are less impactful things, just, talking about overall smaller device. It's thinner, it's curved. We recently revised somebody's because it had square edges and it was kind of poking on the adjacent tissue. And so we for that reason and for the improved efficacy of the new Percept, modified that, but just smaller, less discomfort associated theoretically with the device. And this is just the smart battery, just being able to predict well in advance, based on your current usage, when is the device expected to run out of juice, so that you have plenty of time to get these revised. And I don't know how many folks are in the audience today that have DBS systems or have had them revised, but those revisions are typically about a 5 to 10 minute deal that is done as an outpatient. They're pretty darn simple. So And then the Percept is the name of that battery. We've kind of covered the big deal things, but MR compatibility, ability to uniquely program the independent contacts, brain sensing, and ultimately, it will be able to perform, hopefully in the near future, some closed loop where it's sensing and reacting and not just blindly stimulating. So I think that is the end of the slideshow. So let me come back here and okay, all right, got it. Okay, well, Vince, I'll may just to, again, keep it somewhat informal. I'm happy to go to questions. I don't know how do I view this. Oh, I see the chat here.
Yeah, if it's okay, I'll just there's
Sure.
a couple questions there, Dr. Wallace. One is, who makes a good candidate for DBS?
Yeah. So the kind of perfect candidate for most of us would be someone that has significant motor involvement. And so when I say significant motor involvement, tremor, rigidity, slowness of movement, and things that typically affect the arms and legs. The folks that have a good response to levodopa replacement. So their Cinemat helps them, but it doesn't help them for as long as they want it to, or they're developing significant side effects like the dyskinesias. Okay, and so we like folks for to have had the Parkinson's for at least enough time to definitively prove that they had it. I think 4 years is kind of what's recommended. We want them to have a good response to levodopa. It's just not helping them for as long as we want, and we want them to have pretty significant motor symptoms. Somebody that is kind of the opposite of that would be somebody who says, "Hey, you know what? They're not sure I have Parkinson's disease. Some people think I do. Some people think I don't. The Cinemat, the levodopa replacement therapy, it's really never helped me at all, and I'm having a lot of symptoms with balance problems and swallowing difficulty and memory and dementia issues. Those are typically not things that the DBS would help with, and those are not good candidates. And some of the folks, I'll tell them, if you are wondering, is the DBS going to help with this particular symptom? Just a reasonable rule of thumb would be, if that particular symptom is well controlled when you're really on your levodopa replacement. So when you're really in your on state on your medications, if that particular symptom really seems to be improved, then it's likely that the DBS would also provide improvement. If it doesn't seem to improve, then it becomes a whole lot less likely that that particular symptom. The one potential exception to that is that a lot of folks don't get as much improvement with the levodopa with their tremor, but we can pretty reliably help reduce tremor with the DBS. Okay.
That kind of answered one of the other questions, which is, does the DBS surgery help you get off your medications?
Yeah. So there's a reduction. It's probably in the 20 to 30% reduction of your meds range, and so that can help for folks with some of the dyskinesias to reduce it. It would be unusual for us to dramatically reduce or to stop the medications. Okay, but again, this is one of those deals where we have some of our most powerful data, our scientific studies that show, randomized, prospective data that show that DBS in conjunction with medications provides better long-term outcomes for folks, better quality of life, better, overall control of symptoms than the medications alone do. Okay, but it would be unusual to stop somebody's medications, after DBS.
What about, and this has come up before, Doc, about age? What about age limit? Is there any restrictions there?
Yeah, so for a long time, we would say 75, and in my practice, we've certainly, implanted folks that are older, and so in my camp, I don't really have a rigid, inflexible, age cutoff. Obviously somebody that is very elderly, they have a lot of medical comorbidities, they're on blood thinners, they have significant dementia, and that would not be an ideal situation. But this is we've done plenty of folks in their 80s, as well. And so even though there was a period of time where folks would limit the age to 75 or younger, and in talking to colleagues around the country, that seems to be a pretty common trend, that it's really kind of tailored. When we do these surgeries, it's pretty amazing, even though it seems like a really big deal, and not to in any way imply it's not. Okay, doing a DBS surgery, just in terms of the toll it takes on your body, the blood loss is typically negligible. I mean, we're talking typically within the teaspoon or two range. We make a skin incision in the scalp, but aside from that, the window that I make in the skull itself is about the size of a nickel. There's no real healing or pain that occurs with the window that we make in the skull. The brain itself has no direct sensation. We're not doing anything, to the brain other than, passing this very thin electrode that is typically an atraumatic passage. And so the punchline to this is that there's not a lot of disruption. It's not like getting a hip replacement where there's a lot of muscle that's cut and a lot of blood loss, and there's a lot of rehabilitation that's required. And so that translates, that low blood loss, not disrupting a lot of the normal anatomy to do these surgeries, translates into a kinder, more reasonable recovery period, and one that somebody that's in their 80s would likely tolerate if they're a pretty healthy 80-year-old, or 85, whatever it is. Whereas big surgeries can be bigger deals for folks as we get older. So
that kind of lend itself to, you covered a lot of turf there with regard to age being somewhat of a basis of some sort, at least a substantial consideration. Are there any other risk factors that you didn't mention with regard to age that people should be alerted to, or potential?
Yeah, I mean, in general, we I don't know what we call a risk factor as much as we don't want them to be so far down the path, the severity of their Parkinson's, that the medications have lost the efficacy, the benefit. Okay, so there is somewhat of a window. We don't want it too early. We don't want it too late. And again, that's not an age related thing. That is a clinical state. Where are you on the path of your Parkinson's disease? If you've waited to the bitter end, and you're just getting, you're just radically impaired and you're getting no benefit from the medications, we worry about how much we're gonna help. So we do want that to happen. But in general, we want any medical comorbidities, diabetes, any other, cardiac issues, whatever, as long as they're compensated for. Okay, folks are being managed for those, and they're reasonably well controlled. That's not a problem. Blood thinners, you can be on them, but not at the time of surgery. So you have to be able to be cleared to come off those blood thinners. And typically we would stop those a week in advance, and we would reinitiate them maybe 3 or 4 days, after the surgery was completed.
So that would involve
then,
your physician then.
Yeah, and that's something that we would routinely, kind of coordinate from the physician camp, clearing, whoever prescribed them, whether it was a heart doctor put somebody on Plavix, for example, we want to make sure that he's going to say, yeah, you know what, you're not at that higher risk to have a heart attack. It's safe for you to come off that, so it's a team approach. And then, from the patient's perspective too, obviously if somebody had a lot of dementia, number one, I'm concerned, because the DBS would not help, the dementia, the memory deficits. But if somebody can't participate, with the procedure, they can't answer questions or reliably give us feedback, because most of you know this, but, there is a portion of the procedure particularly for the Parkinson's folks, in which we would have the patient awake, so we make them sleepy. We don't put a breathing tube down, but we make them sleepy for the bulk of the procedure. Then we're ready to evaluate them. we wake them up, and most of the folks, they're anxious going into it, but most of the folks end up looking back and saying, you know what, the anxiety leading up to that was far worse than the actual procedure itself. So we do need folks to be awake for, a portion of the procedure, because, we're looking for the sweet spot. We want to put that electrode in a position where at a low level of stimulation, we're providing a benefit, but we're not creating side effects until we get to a high level of stimulation. And if we have you asleep, we don't know, or if you have dementia and are just not able to participate in a conversation, especially with and having had some recent anesthetic, then it becomes problematic. So significant dementia would be a relative contraindication.
Well, if you recall, I was fortunate to be in surgery with you at one time, not for myself, but as a spectator.
Yeah.
Quite a wonderful opportunity that was as a layperson to experience that. And you guys had some big screen TVs that, competed with some of the best sports bars in our area here, all around. Everybody could see what was going on at any given time from every angle in that room. I wanted to ask you if we've had in the past, it seemed like it was almost like an in vogue type of issue, but would be full awake or full asleep DBS. Do you conduct full asleep DBS? Because I know in the surgery I was involved with, it was in and out.
Yeah. So the short answer is that there are centers that are relying uniquely on just the radiographic, the imaging targeting. I personally still find value in doing what are called microelectrode recordings. So we listen to some of the electrical activity as we're finding that sweet spot, so to speak, and we're using that electrical activity to kind of map things out. Okay, and then in addition to that, we're doing the stimulation. And again, if you're dead asleep, I can't see that the position number one versus position number two of where we're planning on putting that electrode is going to be far superior to reducing your symptoms. But that's one of the beauties of this is when we find that sweet spot, we actually put the permanent electrode in place, lock it into position, and then we do another round of testing to be absolutely sure that the spot that we're putting that electrode and leaving it in permanently is in fact the correct spot. Okay, if we have you asleep, we think we put it there, but if we're wrong and we bring it, you go and get your programming after you've gone through all this, then you're in a situation where there's a risk of us not having been in the perfect spot. So you might not have had as good of an outcome, in my opinion. And the real downside, to having folks asleep is the obvious. It's that who wants to have a brain operation, while they're awake? It sounds terrifying, but again, the reality is that the during the parts that we don't need participation, folks snooze through it. They have no recall of it, no discomfort, no anxiety. We wake them up, and I've never had anybody have a freak out on the table or said, "Oh my God, this is it's very well tolerated," and so I just don't see a big downside. So to me, putting the patient through a situation in which they're awake is a reasonable price to pay to get a better outcome long term from this.
Well, in that surgery that I recollected that I was so fortunate to be a spectator in, it was you probably don't recall it, you do so many, but it was a bilateral, and it was an essential tremor. It wasn't Parkinson's, but I mean, the process was identical. But I recall, as a matter of fact, the cohort there, Chris Larson with Medtronic, was, a big time participant in that surgery. And I recall he had given a glass of water and had a screw lid on it so that it wouldn't. And then he had the patient was awake and you were instructing and someone was instructing you as far as placement. And this woman's hand was doing this. And Chris gave her the water and it's shaking and then you guys are talking to each other and someone's feeding you imagery and you're moving the electrode and before you know it, you start to see this and then that, and then you hear lock it in, So, I mean, that's what my recollection.
Yeah. And imagine that. Yeah, no, it's very accurate. And, they're fun surgeries for us, especially with the essential tremor community. A lot of them, the other name for essential tremor, I realize this is the Parkinson's group, but is familial tremor. And about half of them it was genetic, and a lot of them have had it since they were kids, and probably got made fun of as teenagers. And so for the first time, we're actually trying to accentuate their tremor, and to see that tremor for the first time, and hold that cup up, that's a big deal for them. And it's not that uncommon. We'd have some grown men, shed a couple tears, in a happy way, because of seeing that, dramatic, effect that it can have on the tremor. But yeah, imagine, if we didn't have those folks awake to be able to see that, we wouldn't have definitive verification that we had, found those sweet spot, the right spots.
That from the gallery, that pretty much was the question. But if you allow me here, I just taking some notes. I loved what you were saying. As a matter of fact, you and I had some earlier conversation. I had mentioned to you that I had downloaded a file on a paper that was recently released it was by a company in San Francisco. I think they were. The paper's like 30 pages long, but it had great graphics and what have you. And they were talking about in this paper. I mean, it wasn't even talking. It was something they were doing. It was they had done an implant. It was deep brain stimulation surgery, but the pulse generator, the battery, if you will, was maybe half the size of a match. Size of matches, a book of matches. So they obviously, and they were implanting this directly on the brain with the leads that were closed. They were actual closed loop. They were going from, in this case, forgive me, but I know the amygdala was involved there. So there was some stimulation going on, and they were having such great success with this. Obviously, the hole they cut into the skull would have to be considerably larger than probably the size of a dime that you're currently doing in the back there. But is this where this is heading, Dr. Wallace? Is that closed loop you're talking about?
Yeah, so I think the answer is yes to all of those things. I think that as technology advances, devices are going to become smaller. They're going to become less intrusive. Instead of putting a big battery / pacemaker, beneath your collarbone and running it up, through wires to get to your head, if you can. I mean, the skull is a great place. It sounds crazy, but you can safely take a window of skull out, and you could potentially put a much smaller, like what you're describing here. But the closed loop is going to be, I think where it's going to be a really big deal. And my silly sprinkler in the garden analogy, I think kind of highlights that. I mean, you're gonna have a much more productive garden when you can actually sense what's going on there, and you can react to those changes. And in one of those slides, it said that there are folks that are going to have different fluctuations throughout the day. There's different things that are happening. Their Parkinson's is not in a static state. It changes all the time and throughout the day. And if there is a device that can on the fly in real time read what's going on, and as we collect this data, be able to react and tailor the stimulation. So that's kind of what's exciting about this, is you've got kind of two arms to this. We've got a much greater enhanced ability to tailor stimulation to avoid the directionality, the independent, so we can irrigate that garden, we can reduce the flow and shoot the water just over to the dry spot. But we're also getting this incredible, sensing component of it, what's going on, and that will increase, considerably as the data is collected, and that's going on right now, with the folks that we're implanting the Percept in. So,
can you stimulate and sense at the same time?
Yeah, so that's what that's what's being worked on, is the ability to filter out the stimulation that you're providing. And you can imagine that big stimulation being blasted out there, and then you have these delicate little local field potentials. That's going to be the big deal, is being able to provide stimulation and see how it's doing. At the same time that stimulation is being provided, and it's basically going to involve filtering out the noise that we know is associated with the stimulation.
So the closed loop component then will basically be like a switch, yes, and a deliverable switch.
Yeah, and imagine, to again, I know this is the Parkinson's group, but if as you look at like increasing applications, imagine somebody with seizures, okay, and they're using DBS, for seizure control, and there are certain, a lot of people who have seizures will start to develop auras. They'll start to get a certain sensation like a nausea or start to sweat or something will let them know, and there's going to be brain activity that heralds the impending seizure. Imagine in a closed loop setup where the DBS could see that happening and could shut down, the seizure before it even happens. So it's pretty remarkable technology, and that's sort of, sensing, that the rigidity is getting worse, that the medications are wearing off. That sort of intervention and applying more stimulation, it's going to be pretty amazing.
You'd mentioned early on, there was a couple things here I made notes of them. I have to go back into the gray matter, which isn't what it used to be, so forgive me. But you had talked about accurate reading of the lifespan of the battery. And it was right in the same time you'd mentioned a digital diary. Is this an application? Is that what that is? That the patient goes on their smartphone and then
Yeah.
then you can read it or they can read it, or
7 days of activity.
Yeah, that's right. So it basically allows the patients to keep a log, and now we're not just keeping a log, and it's associated with a smartphone, okay, and then you're able to document those events, and what that's allowing us to do is to from the clinical side of things is to correlate what was going on in the brain. So when you go back and you review, it's sort of like the cardiac Holter monitor. You wear an event monitor. You're having chest pain. We don't know what it is. You go home, and every time you have the chest pain, they hit the button, and then they can kind of focus in on, hey, wait a minute, this is what's going on. You're having some ischemic change. So similar kind of deal. So I think initially those digital diaries are going to allow us to make more sense of what we're observing from a brain activity electrical standpoint that the Percept is recording, around the clock. So,
but you also mentioned too that the hardware has been very reliable, and we know that as a fact. I mean, this has been around for a long time, and it's been very successful. Is there when you start looking for closed loop or some facsimile of a closed loop where you're really gathering data, and then of course you're also stimulating? Is that a bigger drain on the battery? Is that making it less reliable?
well, no, I think the end result's going to be the same. Okay, so let's say that back on the example that I was showing you, where we looked at the rigidity, and at 1 volt it wasn't enough, and 2 was just perfect, and 3 was too much. Okay, now you could be in a situation where you're really on your medication. Same stupid analogy. It's raining outside, and our stupid sprinkler system to our garden still running full tilt. Now with our sensors, we can see that it's raining, and we can shut the. So I think it's going to actually be the reverse. When the medications are working and the electrical activity that is being read, continuously, is showing that there's not much need for stimulation. There's not much evidence of, let's say, rigidity, or the tremor's not really going. Then the device reduces the overall stimulation. If it starts to tremor, you start to see an uptick in rigidity as so I think that ability to adapt and respond appropriately is going to be a heck of a lot better clinically in terms of benefits that the patients are receiving, but it potentially, would extend battery life. So yes, there's going to be a reading component of it, but I think the reading, and this gets into more of an engineering question, but I think that the continual reading of the brain activity usurps a lot less energy than the providing the stimulation part of it does.
So the actual benefit there will be the demand on the battery will be less, even though there's greater demand figuring out what needs to be done in order for that to happen. When you had mentioned, I believe you had placed 3 of these Percept Insight devices.
Well, so there's the 2 parts of it. The Percept is the battery, the pacemaker, okay, and that can be utilized with the older electrodes, and it still allows for that brain sensing, that reading. It allows for the
Data capture,
programming, and so on. We started putting those in last summer, and I think I've put in probably somewhere in the 25 to 30, range on those. So we
Not including the new leads, just on the old.
just the battery, and then the new leads, they just came out. We had a bit of a COVID shutdown where we had to kind of push folks back for a little bit until we were back on elective surgeries. But despite that COVID shutdown within the past few months, we were able to get 3 patients implanted with the new directional electrodes. So.
Well, what I was, I guess, getting at, I'm thinking now from a programming perspective. One, the data has to be read in order to make adjustments, correct? I mean, is that part of it? So, I mean, when we think in terms of people being programmed after their DBS, when you this newer one with the Insight, the whole new package, are they coming in real quick afterwards, and then you're looking at the programming, making adjustments like you were talking about, 0.5 volt, 1 volt, so on and so forth? Is that what's happening now?
Yeah, so they still have to go through the programming, which is typically done in the neurology camp, and the logic in having the neurologist do it is because of what we had discussed briefly earlier, and that is the need to have medications, still utilized. And so most of the teams that do DBS around the country, they do the programming with the neurologist because you don't want one, cook in the kitchen adding salt and the other adding water. You don't want me programming the DBS, which could impact the amount of medication that the person needs, and then they're going to visit with the neurologist, and the neurologist is blindly, modifying the medication. So we want one guy as they optimize that, programming. Now, the protocol is still going to be the same as, one. So the series of events are electrode implantation, either one or both sides. We typically would do, if somebody's going to have both sides and they know it, we're going to normally do that in the same setting. Then they come back as an outpatient procedure. They would get the battery put into place. And then at any point after the battery has been implanted and connected, they would be able to have that device programmed. And so, the programming is they do the bulk of it in the first session, and then they do whatever fine tuning sessions they would need to do. What's that?
Every 3 months.
Yeah, so 3-month follow up. Now, what could change? What would be interesting is, I just saw somebody in the audience had asked, they were having some side effects because of the location of their electrode, and
That's the directional one.
No, this is somebody that
Different.
almost certainly hasn't had the directional one. So this is somebody with an existing, older system that's out there, and they're saying that they have side effects, because the electrode might be a little deeper than what it was intended to be. Okay. Now, what's interesting is that with the new Percept, which is still compatible with the older electrodes, changing out the battery is about a 5 to 10 minute deal. It's an outpatient surgery. I literally make a skin incision, and we pop out the battery, we swap it out, put it back in the same pocket, and I close the incision with glue and some steri strips, and there's very little pain or recovery time. It really is a skin operation, for the most part. Okay. And it is literally about a 5 to 10 minute deal. Well, now with this new battery, let's say this individual that has problems with side effects because of the location of the electrode, maybe we can focus more on those upper electrodes and the ability to program those independent contacts that are higher up individually, and the ability to program them in different ways that was not previously available. It's an interesting idea. I mean, instead of somebody going in and repositioning the electrodes, what if, I would tell that
get a bleeder on that.
But we do a 5 to 10 minute surgery that doesn't involve doing anything inside your head, and we might be able to provide enough improved, programming options that we could get better results and fewer side effects. Again, there's a risk we do that and it doesn't bear out like that, but it's an interesting possibility for folks.
Yeah, and the reason I mentioned that was directional, because there is a question. The question is, I had a directional DBS surgery and having issues with the programming and lots of side effects during programming. I have found out the electrode was placed too deep. And that's why I think I mentioned, because I saw that question, is this correctable currently? or will it be correctable in the future with more technology?
Yeah. So assuming that they truly have a directional, electrode and they have the Percept, the way that I would typically advise folks on that is, number one, we would want to make sure that somebody who's competent in terms of programming had thoroughly, exhausted the programming options to make sure. Okay. Number two is if they did not have, which if they have a directional lead, which is kind of hot off the press, I would assume that if it's a Medtronic system, that it would be the Percept, but if they didn't have that, improved, more modern, Percept, then I would consider doing that. And then the third, step would be is if they have a Percept and programming has been exhausted, I would get a high definition, a stereotactic quality CT scan of the head loaded onto our robotic workstation. Really determine where the electrode is in position. Is it really too deep? Is it in the position that it needs to be? If it's not, and the above boxes were checked, optimization of programming and optimization of the hardware, then you could potentially reposition that electrode. Okay, but that would be something that's in the head, and that would be sort of our last effort.
Right, very invasive. Well, we know, at least I know, there's really 3 manufacturers of directional leads. Is Percept compatible with all?
I don't believe so. I think it's only going to be compatible with the Medtronic ones.
Okay.
So
You would need adapters to fit.
yeah, I mean, it's possible there could be adapters, but I'd have to look into that, whether that's true or not.
And really, and I'm going to close out with this. We've run our time. It's been fascinating to say the least. Someone had asked about slides being available. Slides are not owned by us. However, we did have permission to record this event today, and it will be available on our website probably within the next week or maybe even sooner, so people can access those slides there. Notwithstanding, I just want to thank you. Your time has been well spent. Excellent presentation. Thank you so much for taking the time out with us today, and for Chris Larson being their support mechanism. And so with that, we'll sign off. And thank you for joining us. And Dr. Wallace, I'm going to be probably tagging you again. I hope you'll come back and visit with us.
No, absolutely. Well, Vince, I appreciate all you do, and thanks for inviting me, guys. I hope everybody's doing well.
Thanks, everybody. We'll see you all next time.